Sure. Okay. I'm Dr. Jayapanian. I am it's a very nice presentation, and it's a elaborative talk about heart failure therapy and device management. So you just touch about the left bundle pacing, that is conduction system pacing, particularly in left bundle pacing. Have you any experience because of you have a large volume of CRT patient? Meanwhile, you are left bundle area pacing. Comparatively, it's not a randomized. Comparatively, patient to patient outcome. How do you? How is your experience?
Well, we do LBB area pacing and his pacing, but not in CRT patients. I don't think we can recommend using LBB area pacing instead of the LV lead. I mean, there are absolutely zero data to support that action. We have to bear in mind that CRT is a therapy which is shown to be effective and to reduce heart failure hospitalization and all-cause mortality. So I don't think we can routinely implant LBB area leads instead of LV leads in patients recommended for CRT, unless it's done in a study. So I think we need a randomized controlled trials comparing CRT with LBB area pacing, but I don't think we should advise to physicians to not place the LV lead, but an LBB area pacing lead. Also bear in mind that a lot of the times the LBB occurs distal from the site where you actually screw in the LBB area pacing lead. So we do it in study fashion, but not clinical.
Fine.
Sir, I had a question actually. With all the data that you have presented in clinical practice for a non-ischemic cardiomyopathy, where do you really decide between CRTD or CRTP? Is it if you go by imaging, is there any scar burden that you look at? Is there a scar quantification that you take as a threshold? What goes in your clinical judgment on, leave alone the guidelines for a non-ischemic cardiomyopathy? Because there's always a hue and cry about which patient would be benefited most.
Yeah, so I think it's a very good and prevalent and relevant question, because also we are in Belgium, we are limited by the resources that we have, so we cannot offer a defibrillator to everybody. So secondary prevention, that's a defibrillator. Genetic mutations, that's also defibrillator, so we try to do genetic mutations. If you really have a family history of sudden cardiac death, that's a defibrillator. And for the scar, yeah, we often try to do an MRI if that's possible. And if I have a scar burden on MRI of more than 10% on MRI, then we go for the defibrillator. On echo, if you really have a typical left bundle bench block, we often opt for the pacemaker, because these patients with a typical left bundle bench block, especially also if they have a first degree AV nodal block, they react really well to the pacing part. All of this is always done under the condition that they are in telemonitoring. So we offer all of our patients telemonitoring, and let's say we've done like 1,500 the last decade. Of the 750 pacemakers, we only had to upgrade 3 of them. They were in telemonitoring. So I think based on your clinical judgment, looking at that individual patients, are there comorbidities? Is there scar? Is it secondary prevention? What type of QRS it is, I think you can make the distinction between patients who will need the defibrillator versus the ones who do not need the defibrillator. And bear in mind that if you implant a CRTP in a patient with a left bundle bench block, and ejection fraction improves to, let's say, 45 or 50%, if they will have a VT of 180, they will not die from that VT. It's different if they would have an ejection fraction of 10%. So I don't think there is that much risk of going for a pacemaker in selected patients.
That's quite a wealth of experience and really wise points. Actually, just 2 more queries on that. When you say a scar burden of 10%, do you look at the site of scar, whether if it's a mid-myocardial scar, if it's an epicardial scar? Again, based on the location, is there a different quantification that you bring into your judgment?
I think it depends. If it's an ischemic one, of course, then you have more like localized scar where you had an infarct. So that's different. But if I have a non-ischemic and there's diffuse scarring, I'm a little bit afraid. And that's what you mostly see in these non-ischemics. They either have scar or they have no scar. And these non-ischemics on MRI, they've really these patchy patterns of scar, and then we are afraid, and then we go for the defibrillator.
And with a CRTP alone, does with all your wealth of experience, do you find really a proarrhythmic risk, which was a speculation earlier, when you are pacing around these scar areas, when you have this some epicardial scars and all? Mm-hmm. Does it have a proarrhythmic risk?
I don't see it, to be very honest. I think I've seen it once. We turned on the device and we saw a lot of ectopy, but for the rest, I don't really see it. Also, bear in mind that after the CRT, almost all of our patients are on 10 milligrams of bisoprolol. There is no reason to not improve the beta blocker. And not many people on 10 milligrams of bisoprolol develop ventricular tachycardias anymore.
You have raised many valid points. Improving the medical therapy after the CRT on would make a VT less likely, and the patient well tolerating the therapy even if it comes. Very valid point, sir. Thank you.
Hello, sir. It was an excellent talk. I think we really enjoyed it. And one query from my side, when we are discussing about conduction system pacing, we know like right now the indications are more in favor of a pacing indication than for a heart failure indication. But when you see a patient with a vein is not very much suitable for you to go ahead with a LV lead pacing, do you prefer a conduction system pacing, or you still prefer a epicardial LV lead?
If I cannot place technically in a CS lead, you mean?
Yep. Yeah. Yes.
Yeah. To be very honest, that happens very rarely. I think less than 1%. So that's not really a prevalent problem. In those patients, I probably would prefer now an LBB area lead. Yeah, I would probably go for that first because it's just less invasive. There are not that many risks attached to it. I mean, having to go for an epicardial lead, it's always surgery. It's always, in my feeling, it's major surgery still, because you have to open up the chest. So in those cases, we probably would opt for an LBB area lead. Yeah.
What is your experience of distal conduction system disease coming after an LBB pacing? Now you are placed in a left bundle lead. You have got a narrow QRS at the moment, and on follow-up, not at the time of index implant, on follow-up, you find 1 or 2 years down the lane, the distal conduction system disease coming in.
Yeah, I don't know. I don't have the 2-year follow-up yet of the LBB area. I'm afraid I cannot answer that question. I mean, I think in Europe, many of us now are doing a lot of LBB area and under small clinical studies, especially for pacing indications. I don't think many of us using it as an alternative for CRT. So, and we only are doing it since, let's say, a year and a half. So I can't really answer that question. And that's also one of the reasons why I think we should not be doing it as a replacement for CRT currently, because we don't have the data. And CRT has shown to be life-saving. I mean, come on, we cannot throw away a life-saving therapy because we think the other one might be as good. That's my personal feeling, but I'm taking my hat also now as HFA board member.
Your thoughts on left bundle optimized CRT, left bundle optimized CRT, left bundle and an epicardial LV, and a CS lead, both? For an IVCD.
For CS, what can you
so for heart failure with an IVCD with IVCD morphology, white QRS, for a left bundle optimized CRT, a left bundle with a CS lead as well, both left bundle optimized CRT.
Yeah, I think so. For the IVCD, which is not a typical left bundle, I think the indications are less stringent to go for CRT, of course, as you know. So if you have I think the expectations should be different. I mean, if you have an IVCD, not a typical left bundle, that's a completely different patient than a patient with an LBB cardiomyopathy. So the patient who has an IVCD mostly has a worse LV function because the IVCD is mostly the result of a dilatation of the ventricle. Well, with an LBB, it's more an electrical problem. So my expectation is completely different. If I have an IVCD and I place a CRT, I know that patient will not be as good as a patient who had an LBB. But that does not mean that I'm not going to offer him the CRT part, because I know I can halt the disease a little bit. But of course, if you would take the LBB patient, no implant, and you would take the IVCD patient, no implant, the prognosis of the IVCD patient is significantly worse. So even doing nothing in both of them, you know that the IVCD patient will have a worse prognosis. And what we will do when we place a CRT device in both of them, we might even stop the disease progression in the LBB, but in the IVCD, there will still be disease progression because it's a different reason why that patient has heart failure.
I think our part of the world, India, the conduction system pacing is growing in a big way. That's the reason I think you are getting a lot of questions on conduction system pacing. Regarding CRT, when you are looking at veins, I think there are sometimes we have a luxury of veins. Sometimes you tend to see more than 2 veins in the either posterolateral or lateral region. Do you check QLVs on veins or you take anatomical positions as a choice?
No, I take anatomical positions as choice, and then we measure the QLV to more reassure us that we are in a good spot. And to be very honest, I've never seen a bad QLV if I'm in a posterolateral position. So I think one thing is just automatically follows from the other. So if I have 2 options and I go for the first option and have a good QLV, I'll just accept it. If I have 2 options and they were both are posterolateral, most of the time the QLV is almost identical. It's good, unless of course if you go to an anterolateral position. Coming back to the LBB pacing, I'm not against LBB pacing. I'm against people using LBB pacing instead of CRT without a clinical study scenario. I mean, I think that's not the right thing to move this field forward. I'm not against evolution, absolutely not. But we have to define and we have to do the clinical studies before we can tell to everybody, just do LBB area pacing instead of CRT. I mean, that's my main message.
Yeah, true. Very true. The another question again on the leads, as you just mentioned, there are not there are times when you see that your posterolateral veins are not good enough. You are left with either a posterior vein or an anterolateral vein. In that case, you still go with an anterolateral or posterior vein, or you will consider again a conduction system pacing.
You're pushing me in the corner all the time, but that's okay. I probably would still go for the anterolateral vein first. Many of the times that's also a good option, and there we will do the QLV, and if that QLV follows at the latest part of the QRS, I just accept it. Again, I mean, even in the randomized control trials, it was proposed to go to a lateral position. And a lot of these patients probably also had an anterolateral position, and overall, there was a tremendous benefit of the therapy. Again, we have to use the randomized controls trials, how they have been designed, and they have shown a tremendous benefit. We cannot just throw that away because we feel the alternative therapy, we feel that the alternative therapy conduction system pacing is better without having the data. So I would strongly suggest all of you, you're from India, you do so many implants, do the trial. Do the trial, double-blind CRT versus LBB area pacing. Do it. I mean, I would embrace it, really. But I think, I believe that at best, you'll be equal. You will not be better because the therapy is not sufficiently, I mean, when you do LBB area pacing, when do you stop screwing the lead? I mean, there are so many different opinions. When to stop, how deep to screw, how to program. I mean, it's so complex, especially with his pacing. That's even more complex in my eyes.
Yeah, in his pacing, it's more difficult. But left bundle area pacing, we come to some conclusion. Got a lot of cases getting improved, even become a normal LV in our numbers. Of course, we need a randomized trial. But left bundle area pacing definitely equal to CRT. Some limitations are there. Technical, even non-electrophysiologists are doing CRT. If you are getting posterolateral vein, you park it and come out, and we can optimize it. But in left bundle area pacing, we need to be work technically very sound, and we have to get a better QR or LVAT within 85. Then only you can get the good synchronization. Even my experience, if just getting a narrow QRS, but not up to the mark of getting QR, that patient are still suboptimal results only. So you are work on the randomized trial. Thank you.
Yeah.
Dr. Arun, anything more to add on, or we will move on to next session? Arun, anything to add on, or can we move on to next session?
Just adding one or two questions more from the clinical perspective. When you get a patient with LBB cardiomyopathy, you put a device, his EF recovers, they comes for a PG replacement. What I thought, you implant a CRTD to begin with. So he comes for a PG replacement, and his EF is absolutely normal now. How do you manage those cases?
Yeah, I mean, that's also the question that always comes back. We would like to go for a CRT pacemaker in those patients with regards to cost, and probably because the patient is elderly now, but there is no connection. That's the problem. I mean, then we have to place a new RV pacing lead, which I think is even more cumbersome. So I think all of us are asking to the companies, give us a connection which can connect the ICD lead to a pacing port. And that doesn't exist now, or at least not in Europe. Do you have it in India?
No, we have. Yeah.
The companies, of course, refuse to make the connector, but we should force them to make the connector. So I agree. In those patients, if they have never had a VT, ejection fraction improved, I think you should easily do a downgrade, but I'm not going to place an additional pacing lead in order to get that. Then I'm just going to replace it with a defibrillator, which is not what I want, to be honest.
Okay.
I think, Arun, we have options in India, right? When you are going to put a DF1 CRTD system, you have a patient's lead which can be connected to your CRT pacemaker, and you can just close your defib port if you are not using a DF4 system.
He is asking about RV pacing, YV pacing. He is asking if threshold or RV lead can be off. That's the situation we have. We don't have that option, Lawrence.
We'll have to have an RV pacing lead and then downgrade to CRT PG so as to cut down the cost, because CRT PG becomes cheaper, but you need to place one more RV lead in. So that is we'll have to have one more implant. So yeah.
But do you do that? Do you then place an additional lead?
No.
Yeah, so that becomes more cost effective for me, at least. Yeah, CRT PG is definitely cheaper, and the CF has recovered. I don't see a risk of sudden death actually. So a CRTP on a PG change with one more RV lead becomes easier actually.
You know what I've done in the past, but that's something that of course I'm not allowed to say so. But what I've done in certain patients who are not pacing dependent and who are elderly is just replacing it with a DDD pacemaker, and then just connecting or even the CRT, not connecting the RV lead anymore, that they just have LV pacing only.
Yeah, that's a good point, sir. Even we did it atrial synchronized LV pacing alone in patients who could not afford. And we placed a dual chamber pacer and allowed the RV to intrinsically depolarize, just like adaptive CRT. And that worked in patients who could not afford a CRT. Actually. Yeah, we have published it in Indian Heart Journal, actually. That was from Narasimhan sir's group, actually.
Good. So there are two of us doing it in the world.
No, it's by a teacher of Narasimhan. He brought up the idea. We had a case series we published in our Indian Heart Journal as well.
Okay.